The Committee on Homeland Security will come to order. The committee is meeting today to receive testimony on the federal response to the coronavirus. Without objection, the chair is authorized to declare the committee in recess at any point. Good afternoon. Today, the committee is meeting to examine the federal government response to the novel coronavirus pandemic. As a nurse, I want to open by encouraging everyone to visit coronavirus.gov for the most up-to-date information from the Centers for Disease Control and Prevention. And take care to practice habits that'll keep us all safe. Wash your hands often with soap and water or use hand sanitizer. Don't touch your face, cover your coughs and sneezes, and avoid close contact with others if you or they are sick. We know that the spread of coronavirus has likely not yet reached its peak, and it's affecting all of our communities. I don't think there's a person in this room who isn't worried about an elderly or immunocompromised relative's health, a friend's job, or a child's school closure. Just yesterday, the first 2 cases were diagnosed in the counties that I represent in Illinois. Our jobs as members of Congress is to keep Americans safe by working with the executive branch to lead a strong federal government response, including the House-led $8.3 billion supplemental funding package that passed last week. A strong response must include each of these 3 elements. First, we must continue to support our local and state public health departments, our healthcare system, our emergency responders who are at the front lines of this outbreak. This starts with having reliable data to make decisions, like how to prepare for a surge to our health system and how much personal protective equipment is needed for health workers. It also means developing and disseminating clear, accurate risk communication to the public. America's scientific and public health expertise is unmatched throughout the world, and it must be driving our decisions. Second, we must protect people from healthcare costs associated with coronavirus. Testing and treatment must be widely available at no cost to patients, and price gouging of medical essentials and other supplies must be stopped. If we do not take these crucial steps, the epidemic will worsen because families will avoid seeking care for fear that they can't afford it, and our communities will be less safe. Third, we must soften the economic impact of this crisis on American families and small businesses. This means paid sick leave for every worker, unemployment insurance, and food assistance if needed. Given the committee's jurisdiction, today we will also examine the Department of Homeland Security's role in the coronavirus response effort. The department plays a key role in protecting workers on the front lines of this outbreak, processing travelers entering the U.S., and referring them for screening by healthcare workers as necessary. We will have questions today about the efficacy of this screening and how it's being performed at our air, land, and seaports. We also want to learn more about the department's ability to protect its own workers, whether it has adequate personal protective equipment for frontline personnel such as Customs and Border Protection officers, Border Patrol agents, and transportation security officers. Finally, we want to hear about what plans the department has to ensure continuity of operations at certain essential facilities in case of outbreaks there, such as ports of entry, TSA checkpoints, and immigration detention facilities. Today, we're joined by Mr. Ken Cuccinelli, who's currently serving as the senior official performing the duties of Deputy Secretary of Homeland Security to respond to these important questions. Mr. Cuccinelli is also the department's representative on the White House Coronavirus Task Force. I hope to hear from him about the work of the task force this afternoon. He's joined by Dr. Stephen Redd, a medical doctor and epidemiologist with decades of experience with the Centers for Disease Control and Prevention. It's my understanding that Dr. Redd was due to retire this month, but he's agreed to stay on to assist with the coronavirus response. We thank you, sir, for your dedication and service to our country, and thank both of our witnesses for being here with us today. I look forward to a productive dialogue with my colleagues and our witnesses today. The chair now recognizes the ranking member of the full committee, the gentleman from Alabama, Mr. Rogers, for an opening statement.
Thank you, Madam Chairman. I want to thank the witnesses for their presence and for your preparation. I know it takes a lot of time and effort to be here and prepare for it. We appreciate that. It's very helpful to this committee. As I said last week, our hearts go out to those who have lost loved ones and to those who are currently undergoing treatment. This is a global event and requires a global response. Our country has faced outbreaks of serious disease in the past. In each case, we've marshaled our collective resources and ingenuity to overcome these crises. I'm confident that'll be the case with COVID-19. Congress has worked closely with current and past administrations to prepare for outbreaks just like this. Last summer, the President signed into law the Pandemic and All Hazards Preparedness Act to enhance government authorities and authorize funding for emergency response and medical countermeasures. Since 2015, under Republican leadership, we've increased funding for infectious disease response by 70%. And just last week, we came together in a bipartisan fashion to provide over $8 billion to help keep public officials able to respond to this crisis and expedite the development of a vaccine. I hope the spirit of bipartisanship will continue as we look at ways to shore up the economy in the wake of this crisis. But I'm concerned about the petty political attacks on the administration's response, such as the majority's attack on the vice president. The Bipartisan Commission on Biodefense, as well as the panel of health experts that appeared before us last week, agreed that the vice president should be the one leading the response. The vice president is the only one with a direct line to the president and the authority to achieve a whole-of-government coordinated response to this outbreak. And unlike the Ebola czar named under the Obama administration, the vice president is in the chain of command, and he didn't lobby for the pharmaceutical industry. Last week, we heard from a panel of medical experts who all agree that the government is doing the best they can under the circumstances. Today, we have the CDC and the Department of Homeland Security here to talk about their response efforts. I'm interested in hearing how the agencies are using the supplemental funding Congress provided last week, as well as what additional authorities they need to effectively respond to this crisis. In the middle of a crisis like this, it's very important for political leaders to avoid flaming the fire of hysteria. Our job should be to support the response effort and to provide the public with accurate and timely information to keep them safe. I encourage everyone to heed the advice of our medical professionals and our chairwoman. Wash your hands, stay home when sick, visit the Center for Disease Control and Prevention's website for updated information. With that, I yield back the balance of my time.
The chair now recognizes the gentleman from Mississippi, Mr. Thompson, for an opening statement.
Thank you very much, and I appreciate the Vice Chairwoman's handling of the meeting today. I have some talking problems, so I'll be short. But let me say the witnesses we had last week said absolutely we have to have effective communication in a situation like this. People have to tell the truth. Well, I'll just say some of the things that we've heard in the past. The president called the governor of the state of Washington last week a snake. Well, that state has been the most heavily hit state during this crisis. Our president just can't call another governor a snake. And then, in the same sense, the vice president turned around and said he's one of the best people doing the job addressing it. So I think communication and how you outline this is very, very important. When this issue first came up, a lot of people said it was a Democratic hoax. It was never a hoax. We have video where people said it just should not be. So in the interest of getting and addressing this problem, taking the whole of government approach, I would encourage us to deal with the facts. But it starts at the top. If the top is calling names, people have to respond. And I think going forward, if we can agree that we will not call names, we'll address the issue. A lot of communities are concerned, from New Jersey to New York to Texas, all over. Everybody's being impacted. Most of us who came to Washington this week, there were a lot of empty plane seats on those planes coming to Washington because people don't feel comfortable in terms of flying. Some of the people on the planes have masks. And we've been told by professionals the mask really doesn't address the problem. So I would hope, Madam Chair, that with our experts here today, we'll hear the facts. And with that, I yield back.
Other members of the committee are reminded that under committee rules, opening statements may be submitted for the record. I welcome our witnesses. Mr. Ken Cuccinelli currently serves as a senior official performing the duties of the Deputy Secretary for the Department of Homeland Security. He is also the Department of Homeland Security's representative to the White House Coronavirus Task Force. Previously, he served as Acting Director of U.S. Citizenship and Immigration Services. Mr. Cuccinelli was Attorney General of Virginia from 2010 to 2014. Next, we have Dr. Stephen Redd, who is the Deputy Director for Public Health Service and Implementation Science at the Centers for Disease Control and Prevention. He previously directed CDC's Office of Health Preparedness and Response, where he was responsible for state and local readiness and emergency operations. Dr. Redd is a medical doctor and epidemiologist with 30 years of experience at CDC. Without objection, the witnesses' full statements will be inserted in the record. I now ask each witness to summarize their statement for 5 minutes, beginning with Mr. Cuccinelli.
Thank you, Vice Chairman Underwood, Chairman Thompson, Ranking Member Rogers, and distinguished members of the committee. It's my honor to appear before you today to testify about the work of the Department of Homeland Security, what we're doing to respond to the current outbreak of the coronavirus. Very proud of the work the men and women of DHS and our partners at the Department of Health and Human Services and across the government are doing. The department's top priority is the safety and security of the American people. DHS is taking action at airports and land ports of entry to support HHS in slowing the spread of the novel coronavirus, to say nothing of our maritime work. DHS continues to work very closely with our partners at CDC to route all admissible persons who've been in mainland China and Iran in the previous 14 days to one of 11 designated airports of entry where the federal government has focused public health resources. At all ports of entry, CBP officers continue to remain alert and notify CDC and other public health officials when encountering passengers exhibiting signs of overt illness, regardless of their travel history. DHS CWMD is currently supporting CDC's enhanced entry screening efforts through agreements with state, local, or private sector emergency medical services, public health, and first responder personnel at all 11 designated airports of entry for passengers who have been in China or Iran within the previous 14 days. CWMD supports the collection of passenger information for CDC to provide direct information to state and local public health officials to facilitate contact tracing efforts. CBP and the Coast Guard continue their work to recognize, detect, and assist individuals arriving through our land ports and waterways. In coordination with the CDC and U.S. Coast Guard, CBP has measures already in place at all ports of entry to identify travelers with overt signs of illness to minimize the risk to the public. U.S. Coast Guard reviews all advanced notice of arrivals 96 hours in advance of the scheduled arrival of a ship in port. The Coast Guard captain of the port communicates any concerns stemming from sick or deceased crew or passengers to their Coast Guard chain of command and the cognizant CDC quarantine station, who will coordinate with local health authorities. This process has been working smoothly across the country. At and between land ports of entry, CBP is identifying persons with recent travel to China or Iran and making appropriate referrals to CDC or the local health system. The DHS workforce is our greatest asset, and every precaution is being taken to keep our workforce safe, especially for our officers and agents on the front lines. Ensuring that these individuals and all DHS personnel remain safe and healthy is a critical, and immediately upon the onset of COVID-19 as a global concern, the department proactively took action. The DHS Management Directorate has established a Workforce Protection Command Center to ensure that protective procedures are in place for the frontline workforces who may regularly encounter potential disease carriers, and is working with all DHS components to assess their readiness. CWMD continues to work with the U.S. government interagency, state governors, state and local public health agencies, non-governmental organizations, the governments of Mexico and Canada, and private industry partners and stakeholders on medical and public health coordination and information sharing. The Cybersecurity and Infrastructure Security Agency, CISA, has been assessing the national critical functions for potential impacts to infrastructure and systems from COVID-19, and is working closely with private sector owners and operators to identify issues of concern and ensure continuity of these critical assets. FEMA is providing support to HHS as the lead federal agency in the areas of incident management, resource planning, and federal interagency coordination. Additionally, FEMA remains postured to support HHS with consequence management to anticipate any mitigation actions. The American public can be assured that DHS and its component agencies are taking decisive action to analyze the threat, minimize risk, and slow the spread of the virus by working closely with CDC health professionals and interagency partners involved in this whole of government effort. I want to thank you, Vice Chairwoman Underwood, Ranking Member Rogers, Chairman Thompson, and the members and staff of this committee for the support you've shown the department and the government's effort to respond to COVID-19. I look forward to your questions.
Thank you for your testimony. I now recognize Dr. Redd to summarize his statement for 5 minutes.
Good afternoon, Chairs Underwood and Thompson, Ranking Member Rogers, and members of the committee. Thank you for the opportunity to talk with you about CDC.
Turn on your mic, sir.
Is the mic not on? Maybe I need to get closer.
Thank you.
Can I start over? Good afternoon, Chairwoman Underwood Chairs Underwood and Thompson, Ranking Member Rogers, and members of the committee. Thank you for the opportunity to talk with you about CDC's role in the response to the novel 2019 coronavirus, or COVID-19. Before I begin, it's important to recognize that this is a new virus and a new disease. The science continues to accumulate. We will continue to incorporate that new science into our response decisions and response posture. There are 3 overriding themes that have guided our response. First, CDC's role in this interagency response is built on decades of infectious disease experience and planning for pandemic flu and other health emergencies. Second, our response is dependent on support of a network of dedicated frontline public health workers in our communities, the state and local health departments. And third, as we begin to see community spread of this virus, it will be important for all of us to take action in preventing its spread through common sense public health precautions like hand washing, staying home if you're sick, and particularly for high-risk and vulnerable populations, avoiding crowds, especially in poorly ventilated spaces. I encourage you to visit CDC's coronavirus website to learn more about what you can do, and thank you for the second time we've been able to talk about the website and all the information that's there. From the outset, CDC and our U.S. government partners have implemented an aggressive, multi-layered strategy to slow the introduction of this virus into the United States, to buy time so that our scientists could learn how this virus behaves, to prepare our nation's public health system and healthcare system for the possibility of a global pandemic, which, as you've heard, has been declared today, and to educate Americans how best to prepare for disruptions to our daily lives and risk to our families. The administration's interagency containment strategy has relied upon tried and true public health interventions: early diagnosis, isolation, and contact tracing, travel advisories and targeted travel restrictions, selective use of quarantine for individuals returning from global transmission hot zones. Without immunity or treatment, our nation's public health response has relied upon detection and contact tracing to slow the emergence of this virus into the United States. February 25th was an inflection point for the outbreak when, for the first time, we saw new cases outside of China outpace new cases within China. We have observed rapid, widespread person-to-person transmission in South Korea, Iran, and Italy. And before long, we had detected our first case of community spread in California. So what have we learned? The virus spreads easily and rapidly, mostly through respiratory droplets from sneezing and coughing, going from 30 cases detected by Chinese scientists to over 100,000 cases worldwide in a little less than 2 months. Reports from China based on more than 70,000 cases of COVID-19 indicate that about 80% of patients had mild illness and recovered. 15 to 20% developed serious illness, predominantly in older persons and persons with chronic underlying medical conditions. For this reason, CDC has issued new guidance advising seniors to avoid crowds, stay closer to home, and avoid cruise ship travel and long plane trips. As of today, CDC has received confirmation of more than 900 cases of COVID-19 in 38 states, plus New York City and the District of Columbia. It is with great sadness that I report that there have been 31 deaths from this disease in the U.S. As we experience growing community spread in the U.S., state and local health agencies on the front lines will be making difficult decisions to reduce the spread with CDC guidance and support. Thank you for your support for additional resources to increase public health capacity in our communities. CDC has put more than 630 staff in the field and these are working side by side with other federal partners, state and local partners, and we've had over 1,500 people working on the response both in Atlanta and the field. CDC is committed to this mission, will continue to work 24/7 to protect the American people from this global health threat. Thank you, and I look forward to your questions.
I thank all the witnesses for their testimony. I will remind each member that he or she will have 5 minutes to question the panel, and I now recognize myself for 5 minutes. Americans want to know what they should expect in the coming weeks and months, and our state and local public health workforce and our healthcare system leaders need to know so they can do everything that they can to be prepared. Dr. Redd, I'm looking for numbers here. What are the current upper and lower estimates of total deaths due to the coronavirus that we should expect in the United States?
So I don't have an exact answer to that question. I think it is an important question. I think that there's a lot that depends on how aggressive our public health interventions are to really determine the ultimate course of this epidemic. There are many unknowns.
Yes, sir. What are the upper and lower estimates for hospital and ICU admissions?
I would give the same answer I gave to the previous question. The intensity of our public health intervention measures will determine the ultimate impact of this pandemic.
Okay, and then at current rates of detection and spread, when will California and Washington State run out of ICU beds and then also hospital beds?
Again, the better and more intensive our interventions are, the lower those numbers will ultimately be.
Okay, do you expect CDC to do modeling that would be widely reported through like an MMWR or something like that?
A number of groups are doing that modeling. I'm not sure what our plans are. We're in communication with modelers from the UK and around the country on those sort of things. A lot of that has to do with estimating the value of interventions that might be undertaken and where they would have the greatest impact. I don't know whether or not those things from inside will be published, but there is a lot of information out there already.
Okay. For our health system to prepare to handle a surge in patients while protecting its workforce, providers need to be able to test every patient who meets the criteria based on symptoms and exposure. But we know that right now, as the governor of Illinois just said this morning, not everyone who should be tested has been. Dr. Redd, since December, how many Americans who meet the current criteria for being tested have actually been tested and received their results?
I can give you the number of people who have been tested, and let me find that in my cards here.
Okay.
The guidance has changed, as you know, recently.
I know. That's why we're asking about the current criteria, sir.
Right. I think we're around a little bit more than 1,700 people have been tested by CDC. There's a lot of testing happening in state health department labs now. Let me, if I might, take the opportunity to talk about, and tell me if you want
Well, Dr. Ed, what we're really trying to understand is the number of tests that have been completed, how many tests need to be done to accurately depict community levels of spread in the United States. Do you have that figure?
What I'd like to do is walk through how the laboratory testing works in the United States.
Okay, Dr. Ed, we've heard that briefing several times here in the Congress. We have some very specific questions, sir. What's your plan to support states and communities to get those tests done? And when will that be done?
So we've taken aggressive action over the last several weeks. CDC has sent material sufficient to test 75,000 people through the public health system.
Right.
There are over 1 million tests available through the commercial system.
Yes, sir.
Both of those numbers are increasing as we speak.
Right, but my question, sir, was what's your plan to support the states to get those tests done for every single person who should be tested that meets the current criteria? There's a big gap between 1,700 and 75,000 and 1 million. Those are the three numbers you just outlined for us now.
That's true. I think that there are two different systems in play here. In the public health system, and this is not just for this disease, but in general, the role of the public health laboratories are to detect cases early of new diseases and then to be able to do representative testing to estimate the overall burden of disease.
Right.
There's a separate system, the clinical system, which is really for clinical care.
Yes, sir.
Make sure that a person gets treated for the right disease, that we don't assume that he has COVID-19 when there's a different treatable disease. And that is the much larger capacity that is actually being implemented rapidly compared with previous efforts with new diseases.
Okay, I'm going to stop you right there, sir. Is every test result from both the public and the private labs being fed into the flu surveillance system? Yes or no?
Right now, we're working to include the commercial laboratories in that system. The large commercial systems are being included. The public health laboratories are being included. There are others that are going to be kind of outliers that we'll work to include, but that would be the ultimate aim.
Okay, while there's still a lot that we don't know about the pathology of the coronavirus, we're seeing that seniors are among those experiencing higher mortality rates. So in addition to the coronavirus.gov that we both spoke about, CDC has a coronavirus information hotline, as I'm sure you're aware, for those who don't have internet access or who may not be as internet savvy, like some seniors. When the committee staff called the hotline, they consistently faced wait times of 30 to 60 minutes. How is CDC working to improve this hotline?
Let me get back to you on that. I think that's a very important thing that needs to be corrected, and so we'll take action on that.
Just more broadly, sir, our job is to steer the federal government towards the best possible outcome for public health. Modeling estimates help us evaluate outcomes. Surveillance informs modeling, and tests inform surveillance. We need to get all three right, sir, and we'll be making some really important decisions without a comprehensive view of what we're facing. So, Dr. Red, we're going to be sending over some follow-up questions for you in writing, and we would appreciate your help in ensuring a prompt response. Thank you. I now recognize the ranking member of the full committee, the gentleman from Alabama, Mr. Rogers, for questions.
Thank you. Mr. Cuccinelli, this morning the CDC director said Europe is the new China in terms of outbreak. Is CBP doing more screenings of international travel from European countries to the United States?
So as each country, or in this case region, becomes more and more problematic, it obviously gets reviewed on a day-to-day basis. And I would tell you that it isn't just CBP. TSA is involved, CDC is involved. This is one of the things that the task force has considered literally on a daily basis as we've watched this pandemic move around the globe. As you know, I'm sure there is exit screening going on in Italy in particular, but Europe presents a unique problem. And because of the Schengen zone, where their borders effectively don't have borders for purposes of travel, there's 29 countries that we have to confront here. And the question arises, does treating, we'll take Italy, we'll continue with Italy, Italy in the fashion we would China or even South Korea as a unitary entity even makes sense? So what the task force came to with respect to Italy is we are testing, in fact, the Italian government is doing it on the exiting side for direct flights to the United States. That's about half of those flights, very close to half. They have dropped from above 7,000 to just above 1,000 a day. So there's been a substantial drop in that travel. The reason that we chose not to expend the resources to capture the indirect flights is by way of scale, don't hold me to these exact numbers, to capture the last 2,000, 3,000, 4,000 travelers from Italy, depending on the day, and that was at full flight capacity, would require screening approximately 100,000 people. And those are resources that just, relative to the cost benefit, were more appropriate to apply to public health efforts other than that screening. So in Korea and Italy, we have allies who we trust and who are transparent doing exit screening. We're, of course, doing entrance screening for those from Iran and China or who've been through there. But the question is a live question, Congressman, about how to treat Europe as a whole. You've seen Department of State and CDC warnings go up. That is not to the level of using legal authorities to block travel yet, but it is under consideration.
Well, and it should be. That's the reason I brought it up. Right now, we're just dealing with a handful of those countries, as you know.
Right.
Given the freedom of travel throughout the EU, my view is we should be treating it as a region, as a unit, and expecting them accordingly. Let me ask, we just passed in a bipartisan fashion an $8.3 billion supplemental to help with this. I know a lot of that's going toward vaccine development,
Right.
but it went from $2.5 billion to $8.3 billion real fast. Tell me how that money's broken out. What you going to do with it?
Well, as you probably know, the money that DHS receives comes through HHS. So I'll give you an example. FEMA has been with ASPR for about a month now, at their request as the lead federal agency in HHS, and our FEMA is reimbursed for those services effectively through interagency agreements. So the dollars you're describing from the supplemental that reach DHS come through HHS in exchange for services in accordance with the law.
Is it just FEMA, or won't CBP get some of that money?
Right now it is just FEMA. CBP, CWMD, the Coast Guard, TSA are all operating out of their base budgets for all the work they're doing, as is the S&T as well.
Do you expect that to be sufficient, given the new
For the moment, we do, yes. If some things would have to change for that to not be sufficient, but so far, none of those conditions have arisen.
Dr. Ridd, the Chinese government failed to give us notice for 2 months from the time of the outbreak until they did make the international community aware. What damage did that do to our ability to deal with this in a better fashion, if any, that you're aware of?
I think there's some things that they did well and others that they didn't. The reporting the outbreak quickly, posting the sequence of the new virus. There did appear to be a period of time when probably things were going on that weren't getting out of China. I think there were questions about whether there was human-to-human transmission, that initially it appeared it might be just people exposed to animals. So I think that was a period of time when we were, there's not really anything we would have done differently. We were working on a diagnostic test. We were sending materials that started the ball rolling on vaccine production. As you know, within weeks of identifying the outbreak, the restriction of travel from China reduced travel by 90%. I think that was a very helpful move to prevent more cases from China coming into the United States.
Thank you. Madam Vice Chair, I yield back.
The chair will now recognize members for questions that they may wish to ask the witnesses. In accordance with our committee rules, I'll recognize members who are present at the start of the hearing based on seniority in the committee, alternating between majority and minority. Those members coming in later will be recognized in the order of their arrival. The chair recognizes for 5 minutes the gentleman from Mississippi, Mr. Thompson.
Thank you very much, Madam Chair. In my earlier comments, I talked about the importance of transparency and communication. The public only gets what we tell them. And if we don't tell them accurately, then it's misinformation. Best example I can share in my opening statement, the very first briefing we got, we were told that there's an 800 number. The briefers, as members of Congress, the briefers didn't know the 800 number. They had to go get the number and bring it to us. Now I hear that the number's working, but if as a member of the public who would call and be put on hold for 30 to 60 minutes, it's just absolutely too big a problem. So I hope that you look at it. Two of the people we heard from last week, one was a former head of CDC, and the other was a respected researcher from Johns Hopkins. They made very clear to us that communication and transparency in this kind of situation is absolutely important. So, Dr. Redd, can you tell me if the coronavirus task force is carrying out its meeting at a classified level, or are they open?
I know that the meetings are being held in a classified facility. I don't think that they're classified.
Well, I want you to check, because I think there are some challenges in that arena because they are, in fact, classified. And part of the problem a lot of us are having is an overclassification of information to the point that the public doesn't know. So look at that.
Actually, I'd like to agree with your major point, which is I agree that communication and information is a critical tool in combating the outbreak. People need to know what's happening. They need to know what kind of actions they can take to protect themselves. And it is really one of the most important tools that we have at this point.
So in line with the chairperson's question, how many test kits do we have as of today?
So on the public health side, 75,000. On the commercial side, over 1 million. It's somewhere between 1 and 2 million right now. The numbers are increasing rapidly.
So how would the test kits be dispersed?
So on the public side, they go to state health department laboratories and other laboratories that are part of our network for influenza surveillance. Actually, on the commercial side, it's however that system normally works. So it depends on the company. Some of them have facilities.
Well, you know, we're trying to help the public. And the public, you tell them we have 1 million test kits, but if somebody from CDC in your position can't explain to me how the public can access those kits, that's not very helpful.
I agree with that. I think that what people need to do if they feel that they are in need of a test is the first thing would be to call their doctor. The doctor would then, depending on how they have access to the test, it could either be through the commercial system or it could be through the public health system.
So are those 75,000 test kits that you talked about that are publicly available, does that address all of the current needs here in the United States?
It doesn't, and that's why the commercial manufacturers are such an important part of this.
Absolutely, but are they talking to each other? Get back to
yes. No, I think the answer is yes.
You know, we're trying to give the public some comfort that if you say we have 1 million kits, then there's a process that's defined for those 1 million kits to be accessed. And we don't have that based on what you're telling me. And I think one of the reasons we're here today is to put some clarity on how we address this situation.
Yes, sir. I think that the patient experience here is really critical, and that when they need a test, they can get one quickly and get the results quickly. That is the aim that we're hoping to achieve.
Thank you. And if the chair will indulge me just for, Mr. Cuccinelli, on March 1st, 2020, a district court judge ruled that you were not lawfully appointed to serve as the acting director of USCIS and that accordingly, the reduced time to consult and prohibitions on extensions directive must be set aside. Are you still serving as a senior official performing the duties of Director of USCIS in opposition to what the court ruled?
No, sir. The court ruled that in my position as principal deputy at USCIS, I was not properly occupying the position of acting director of USCIS. That is obviously something we're still analyzing and obeying the court order with respect to the 5 plaintiffs. My current position as senior official performing the duties of the Deputy Secretary derives not from my previous capacity as acting director of USCIS, but from my official position as principal deputy of USCIS. So as I perform the roles I'm here doing today as a senior official performing the duties of Deputy Secretary, that is not affected by the court's ruling. The court did not rule that I am inappropriately occupying my current position. It was the prior position.
So that's your interpretation of the court?
No, sir, that's the ruling.
Well, have you had the counsel for
Yes.
DHS look at that?
Yes, sir.
Did they provide you something in writing?
No, sir.
So what they just told you?
Well, it's pretty simple and straightforward, Mr. Chairman, so it wasn't hard for them to explain it to me.
Well, I would, as chair, we'd like to get it in writing, because I think the court was fairly clear that your present position was not consistent with the law. And in it, we are trying to massage it, just gets around it. But we'll look forward to getting that correction. I yield back.
The chair now recognizes the gentleman from New York, Mr. Katko, for 5 minutes.
Thank you, Madam Chair. Mr. Cuccinelli, is there anything else you want to add to the last line of inquiry before we proceed? No other questions?
I would just point out the timeline. It might help understand the ruling. The case was filed last summer when I was serving as the acting director of United States Citizenship and Immigration Services, as assuming that vacant slot from my position as principal deputy. The hierarchy, if you will, of the deputy secretary position as it currently stands traces back to the principal deputy for the United States Citizenship and Immigration Services. It does not trace back to either the director or acting director phrased in any way. that is why I gave the answer to the chairman that I did, and it was why I got the legal advice from counsel at DHS that I did.
Thank you, sir. Dr. Red, I want to drill down a little farther in the previous line of inquiry as well. I'm trying to get a handle. So you have 75,000 tests in the government, in the government sector. You have 1 million tests in the private domain. What's going to happen to those 1 million tests? Where do they go?
So those, the purpose of those tests would be a clinician, a doctor, nurse practitioner, physician's assistant could order a test, and that would go just the way any test you would get in a doctor's office would go, would be sent to a commercial laboratory, either at the hospital or one of the large companies. You'd get a test result that would come back to your doctor. We're working on making sure that that information also is funneled into the government, so we'll be able to track those tests. But it's essentially a way of providing a test that could be used for clinical services, where public health testing generally is to detect the first cases and then to do surveillance. You don't have to test every case to do surveillance, but for clinical care, you do need a test for each person.
So I just want to make sure I understand this. Was it fair to say that you have the 1 million tests that are already available, plus you have 75,000 more tests, and all of them are getting in front line one way or another for testing of patients?
Yes, sir.
Okay. And how much more are going to be expected in the next few weeks that are going to be produced?
So the timeline I'm not so sure on, but it's going to be additional millions of tests in the commercial sector.
Okay, good. That's good to hear. Now, when we get these tests out there, it's fair to say that these numbers are going to go up. The number of positive tests are going to go up and go up significantly. Is that correct?
I think that's fair to say that we're going to identify additional cases with more testing.
Okay, and as these numbers go up, you're going to have to act accordingly on what's been considered by the World Health Organization now a pandemic. And I think we need to have the American people prepared for the fact that we are going to have a very serious rise in the number of cases. Has there been any estimates as to what they think it's going to be, the numbers next month or so?
So I think the total numbers really depend on the aggressiveness and intensity and effectiveness of our public health measures. One of the things that is happening just in our strategy to respond, early on, we wanted to identify every case, identify the contacts of that case, recommend self-monitoring to prevent further spread. At this point, the individual measures in some parts of the country where there is intense community transmission, those measures are not appropriate, that there are more important things to do, and that is really when we shift to community measures, such as making sure nursing homes are especially protected, canceling large gatherings, recommending, as we have, that people that are at risk, seniors and people with chronic medical conditions, take different steps to protect themselves from becoming exposed. So it's a shift from a kind of an individual level case tracking to something that's broader and applies to entire communities.
As a matter of precaution, should we be doing any of those things now and not waiting until we get all these positive tests? Or what should we be doing now?
We should, and in fact, we are in King County, Washington, in Santa Clara County, in New York City. In fact, today, I think maybe just as the hearing started, there was guidance posted based on a guidance document that we released a few days ago, but tailored specifically for King County and Santa Clara, working with the health departments on what does it mean to actually apply this guidance to your community in the situation that you're in right now. I think that in general, these measures are more effective the earlier they are implemented, and we've seen that in other parts of the country, world, in Singapore, Hong Kong, where they've taken very aggressive measures, and in those cases had really good success in preventing the kind of transmission that we'd like to prevent.
Okay, and lastly, the line of the lab testing, could you just briefly explain to us, just so we're clear, how does the lab testing actually work?
So a specimen is obtained from a person. We're actually, the way that it's been done up now is a nasal specimen. So there's a device that's stuck in the person's nose to collect a specimen, a throat swab. That is put in transport medium. It's transported to a laboratory. There is a process of denaturing that specimen that might contain a virus. That denatured specimen is then put into a machine that assays for specific parts of the nucleic acid, the genetic material of the virus. There are also a set of positive controls, so to make sure the test would find it if it's there, and negative controls to make sure if it's not there, it wouldn't be detected. That then yields a yes or a no result. It also can tell you the concentration, something that's called cycle threshold. That's basically the number of times the machine has to go through this cycle. So a high number means there's not that much virus there. A low number means there's a lot.
All right, thank you very much. Yield back, Madam Chair.
The chair now recognizes the gentlelady from New York, Ms. Rice, for 5 minutes.
Thank you, Madam Chairwoman. Mr. Cuccinelli, during the past public health crises like Ebola and H1N1, the Department of Homeland Security played a pivotal role in a clear and coordinated federal government response. With the coronavirus, our state and local governments have stepped up to fill this role. States like New York have had to respond quickly to deploy emergency management and to work with local partners to keep our citizens safe. They, instead of your agency, are at the front lines of this outbreak. So for some reason it appears, and maybe you can enlighten me if I'm wrong, that DHS has not been on the front lines like they have in prior epidemics. And so could you clearly state what DHS's role has been in responding to the coronavirus and what you see as your role going forward?
Certainly. As we move further and further away from containment, which is where the Department of Homeland Security has a significant role, and into mitigation, which we've been doing for weeks now. As Dr. Red has referenced implicitly a number of times, the frontline folks, and just pure volume of numbers, are your local and state public health authorities. We're following the pandemic plan put in place 2 years ago, which was the most recent iteration of that plan, and it in fact calls for extensive cooperation with the federal government supporting local and state efforts. The sheer number of medical and healthcare professional personnel required to address a pandemic like this puts us in the position of necessarily relying on state and local officials to be frontline fighters in this effort. And I'll give you an example. When we saw the Grand Princess problem developing off the coast of California, we had a unified command set up between the Coast Guard, CDC, California. But in practical terms, because those people were going to land in California, were most likely to be impacting California healthcare facilities and capacity.
Going to tourist destinations, there's no public gatherings. Should there be anything else and guidance that we give beyond public health, washing your hands, giving a social distance? Should we be telling our businesses to go to telework if at all possible? Should we be getting people out of offices and schools? Not because this is such a terrible threat, and I don't want to incite, I'm just saying preparedness helps us blunt, unnecessary panic.
Preparedness does help. I would point to Singapore and Hong Kong as examples of aggressive early action that has blunted the epidemic.
So,
I think in the case of Italy, it may be a lot too late.
It got away from them. So what are the 2 or 3 other things that people should be doing besides the public health guidance to minimize the spread of this illness? Since Michigan, we just got our first 2 cases yesterday.
So I think that there are some individual actions and there are community actions. I think that all of these, protecting the elderly and medically vulnerable is the highest priority because those are the people that are going to have the worst outcomes. So I think there is a lot of work around nursing homes in particular that needs to be undertaken to prevent the virus from getting into the nursing home. Things like reducing the number of visitors. If anybody is sick working there, being absolutely certain that that person isn't allowed back in. That people who work in one nursing home don't work in another nursing home. That when a patient is transferred from a nursing home to a hospital, they're not sent to another nursing home. Okay. These are kind of things that are known to spread other kinds of infections in that setting. And I think that the work that we do to protect people in nursing homes and the elderly is critical.
So can I ask a quick question? Because again, on the public trust issue, the issue of testing. So I will tell you that the sense in the public is that there's not enough tests. I'm glad to hear the numbers that you all offered, that there's 75,000 public health tests and another 1 million available commercially. We are not getting those to our states in a way that feels reassuring to people. And I guess I'm confused on why we're playing catch up on this. My understanding is we've tested 8,500 people across the country, but that South Korea is capable of testing 10,000 people a day. Can you help me understand why they're able to do that?
They have implemented a different system than the one that we're using. I think that we probably should be scoring ourselves on the ultimate impact of the epidemic and how well we control it. Testing is a part of that, but it's not the only part. So I am not sure. I mean, we don't have really good visibility on who's being tested. And if you're just testing people who are perfectly well, have not had any exposure, have a negative test, I'm not sure that really contributes to the public health outcome. Okay. I do think that, I agree with what you're saying, that there is a sense that we haven't done enough in testing and we're doing everything we can to correct that. And I also agree with your statement about the importance of trust.
So I'm sorry, I just have one quick second. So a lot of us really do respect the head of the CDC, Mr. Fauci, Dr. Fauci. He's gotten us through a lot of crises. I guess I would ask, that while you've devolved a lot of things to the states, and I understand things are going to be certainly a little bit different, I guess I'm just a prisoner to the fact that I was in New York City on 9/11, and whatever people think of Rudy Giuliani, he was clear, he was available, He was telling us what was good and what was not good, and I'm telling you that people are missing that. They're feeling like they want clearer guidance, and my strongest recommendation is that Dr. Fauci be allowed to take that role to reassure the country.
The chair now recognizes Mr. Crenshaw for 5 minutes.
Thank you, Madam Chairwoman. Thank you both for being here. I'll actually continue along that line of questioning because I have similar questions about what is the standard we're trying to achieve with testing. We do hear that South Koreans are testing huge amounts of people, and it makes people feel like they should also have a test whenever they want. Now, of course, you have to buttress that against the reality that we come up against, which is, are we then excluding people who actually need the test? And so I do want to get a more detailed sense from you of where we should be. What is the right realistic standard that we should be trying to achieve with respect to testing and availability of testing? Should the threshold be lower than it currently is? Because right now I believe you need doctor's orders to get a test.
So it's a really important question. I think right now there's this sense that you should just be able to get it, anybody should get a test every day if they want, and I don't think that is really helpful to the response. I think that in communities that have transmission, it is very important to do enough testing to understand the epidemiology of the disease, and that is something that is a health department role. So that kind of testing is critical, and there's some questions about just the kinds of things that kind of testing could help us understand whether schools are an important place for virus transmission. Children don't get as sick as older people.
Right.
We're not really certain if school closure is the right move, so we can't
I
understand
agree with that
without
general
testing.
philosophy, and so you've laid out the philosophy of standardizing testing. So the next question is, should we be reaching for a different standard than we're currently implementing, or should we keep it about the same?
I think that a clinician saying this is a person that needs a test, and that can be a pretty low threshold. I think that's the right threshold.
That's still the right threshold. And Admiral Red, you were also incident commander for the H1N1 pandemic response in 2009. Can you tell me what major differences there have been between the current response to coronavirus and the H1N1 a decade ago?
Yes, I think the two biggest things are we had a drug that worked against the virus, and we were able to produce a vaccine within time to blunt the outbreak, or at least to have it available during the peak of transmission. I think the other, we knew more about flu than we know about this virus, and some of the issues that have come up about when people can transmit the virus wouldn't have fit conventional wisdom. So I think there's more that the scientific community has to learn about this coronavirus, even though a lot of uncertainty in H1N1,
Sure.
but less.
That goes without saying. I mean, but the actual response, has it been dramatically different?
It's a much larger response than we had for H1N1. I think there are more sectors of government involved. We didn't do a lot of the things that we're doing now because they weren't appropriate. The border issues, we had cases here. The pandemic was first recognized in the United States, so that's a totally different situation.
Speaking of border issues, Mr. Cuccinelli, in the face of a global pandemic, should we have less security at the border or more security at the border?
Under those circumstances, more, of course. I mean, the greater your operational control of the border, the less incentive there is to attempt to pass through that, and B, this is just a numbers game. The less chance you then have of people who may not even know that they're infected. Because to Dr. Red's comment about things that are different from H1N1, the biggest one for this non-medical person is asymptomatic transmission. And that presents dangers that you can't even understand when they're right in front of you.
And do things like physical barriers, additional technology, and more personnel increase our border security?
Absolutely.
I want to ask you both about our medical supply chain and how reliant we appear to be on China for some very basic things like generics, antibiotics, things like that. Could you both discuss the current state of our medical supply chain, and specifically how the Chinese shutdown has affected it, and how we can get better? How can we become more self-reliant in the face of future pandemics?
It's an important question. Unfortunately, to be able to answer your question directly, in the department, that area is handled by the Assistant Secretary for Preparedness and Response.
So I've been, of course, part of the President's task force since January, and this has been a focus for us. And I would note, Congressman, that if you go back and look at things like that first 212F proclamation, you'll see, and how we unrolled it, you'll see that we made we accounted for economic activity, not because of the money, but because of the supply chains to which you're referring, and not just medical. At FEMA, for instance, and CISA, we keep track of 7 different sectors. Healthcare is just one of them, transportation, energy, others. And because of the interconnectedness of our economies and societies around the world, we thought it very important to keep that cargo flowing, both by air and sea. And we've made accommodations to do that. I think that a lot of people's eyes, not just in Congress, but in the executive branch as well, have been opened to some of the nuances of the supply chain reliance. My understanding, and I'm not the expert, but I'm here and you want your questions answered, my understanding is that we're not in danger on any particular drugs with respect to interruptions from China at the moment, not in any significant way, that there's substantial, I'll call them stockpiles, but they're working capital equivalent of drugs. And there are substitutes that fill the needs for where we do have gaps. That gets us out of months and months, but when this is over and we all step back and ask ourselves, what did we learn here? This is definitely going to be one of the subjects we're all going to want to come back to and sit down together. And as Congresswoman Slotkin noted, and as Vice President has said, we're all in this together. Well, if history's any guide, we'll be in it again together sometime in the future. So,
Thank you, Madam Chairwoman.
Thank you. The chair now recognizes Ms. Watson-Coleman for 5 minutes.
Thank you very much. Dr. Redd, one of the functions of the CDC is to collect information, what's happening to our communities across the country. I know that the CDC is no longer depending upon the state tests to come to you to be confirmed before they can move forward with the decisions they have to make. But are you all doing anything to collect all the information so that there is a central place where the information can be held, and are you disseminating it?
We are collecting information from the states. The status of the tests that the states are doing, they are performing the diagnostic test. They're then actually sending the clinical specimen to CDC for verification.
That's not what I'm asking you, because the CDC director said yesterday that we're not depending upon, they're sending it to the CDC for verification now. You're going to believe what's found in the states, so what I'm told.
There's this designation called presumptive test.
Yes.
We're encouraging them to take action on those results, yes.
What I really want to know is, are you collecting the information? Is there going to be a central point of collecting the information? Because the one thing, and Ms. Slotkin kind of referred to it, we don't know the extent of what is happening in our communities. And we experience an incident daily. And so it becomes a new phenomenon. And so we'd like to kind of have greater expectation than we have now. And we don't have that sense of confidence coming from the CDC or from the White House.
Let me describe in a little more detail what we're doing, because we are collecting the results of tests that are being done at states. The other thing that we're doing is working with our system for influenza, where we're testing specimens that are being collected with people that have respiratory illness in Santa Clara County, San Francisco.
Are you also collecting the number of presumptive cases? Are you collecting the data that the states are finding that X number of cases? New Jersey's got what? I don't even know today. It's more than it was yesterday.
We
are
are.
You collecting that
we
information? Are. Okay, thank you. Thank you. This is a question. The CDC has reported the more than 600 confirmed presumptive cases. And so we're all concerned that everyone is given the kind of screening, testing, and whatever treatment you can get, irrespective of who you are. So this question has to do with the conversation that's been developing around this immigration enforcement-free zones. And so, Mr. Cuccinelli, I guess for you more than anyone, I know many health experts and legal experts are saying how important it is for these people to be able to go in and be tested and not fear being exposed to immigration enforcement. Have you all had that discussion at all in your
Yes.
whatever it is you have?
Yes, we have.
And where are you on that?
And ICE has a pre-existing policy, and I mean pre-existing the virus, where they don't do enforcement in healthcare facilities, doctors' offices, except under unique single case circumstances. So that is not an issue with respect to virus testing or anything of that nature.
So those individuals don't have to
repeated that
fear
publicly.
those individuals don't have to fear trying to get tested or treated or whatever.
Correct.
Okay, all righty. Mr. Cuccinelli, the president has touted that measures the administration took to try to prevent the infection from coming into the country by screening certain passengers coming in. We're told that there have been more than 40,000 people who've been screened, but only one of those passengers has actually been confirmed positive with the COVID-19. Meanwhile, 2 of the people conducting the screening, they work for you, have tested positive in addition to 3 TSOs. Can you tell me if you think these screenings are effective and if you think that this is where we should be applying our priority resources? And if so, why?
So obviously the screening is at the 11 funneling airports that you're referencing, and my most recent data is consistent with your comment about 1 person being quarantined, although over 30,000, over 34,000 have been asked to do self-isolation and then communicate with their local public health authorities. And we don't know, we don't go back to those to find out how many ultimately became positive. Again, this goes back to the asymptomatic problem of people coming through screening. They won't necessarily show symptoms.
Well, you know, having information come back, having information collected, having information in a central location and having information available is something that's very important. And it seems to be a big gap in that, in what we're experiencing right now. And that's very troubling and concerning. My last question. Today, Governor Inslee just banned gatherings of 250 or more in Washington state. And Governor Cuomo yesterday ordered a 1-mile containment around New Rochelle. As federal leaders charged with responding to this virus, can you tell the committee whether you had any direct involvement in the decisions that these governors have made to try and to contain the virus? Either one of you, is that yes or no?
Yeah, I certainly can't speak to having personal involvement, but both states have been in deep conversations with their federal partners, DHS, CDC, and so forth, for some time now.
Okay, thank you. I yield back.
The chair now recognizes the gentleman from New Jersey, Mr. Van Drew, for 5 minutes.
Thank you, and thank you for not retiring, and thank you both for being here. So I just want to clarify a few things in my mind, which I think maybe would help everybody, and sort of almost a little bit rapid fire, but we go back to border security. I just want to make sure this is clear to people because I think it's clear and common sense to me. If we have open borders, if we have sanctuary cities, sanctuary states, if we have people traveling around that just got into the country not in the normal route, is it your feeling, Mr. Cuccinelli, that that eventually could increase the risk without question of these types of diseases?
Oh, well, certainly, absolutely. That's a simple matter of math.
I mean, there's nothing complicated about this. If people, for lack of a better term, sneak into the country and haven't gone through the normal legal immigration route, we have a larger chance of the disease spreading more. Is that correct?
Yes, in the legal route, we have an immediate screening for illness that's part of the legal requirement for entry.
Okay. The second question that I have is about the travel restriction that was originally criticized when the president put the travel restriction on China and was seen as something abhorrent and terrible. If you were to look back now, would you say, Dr. Red, both of you, that that was obviously, as much as we have issues and problems now, the issues and problems and challenges would have even been deeper and greater? Is that correct?
Well, our understanding at the time when we recommended it to the president and when he had that discussion with him was that the academic models suggested not to do that. So our advice was contrary to the then existing models as it was described in the task force. We made the recommendation anyway. The president was well aware of that sort of contraindication, and he adopted the recommendation, and we universally now believe we benefited tremendously
Obviously, it was fortunate.
from adopting those measures.
Okay. In canceling large events that we spoke about, wouldn't it be dependent upon the state? I mean, just thinking about how large the United States of America is compared, not to China, obviously, but to a place like Italy or some other areas, wouldn't it be on an individual case-by-case situation too? Whereas, for example, I understand in Washington where you might want to cancel any large gathering, where in Nebraska perhaps you would not. Is that accurate at this point? Is that how we would deal with that?
It most certainly is, and it's why it's appropriate for Governor Inslee to make that decision. It's why it's appropriate for Governor Cuomo to make those decisions, and not for us sitting here in Washington to impose those decisions. That's part of the partnership. The guidance you've heard Dr. Red talk about has been flowing freely. It's changed because this virus has literally not been known in human beings for 3 months on the planet Earth yet. So we're still learning, and we're going to be learning for months to come, but that's why those local sensitivities and letting local authorities have final say is so important.
Let me understand testing for a second. So, perhaps, hypothetically, I don't feel well. I feel that possibly I have the coronavirus. I call my doctor, my nurse practitioner, whoever the appropriate health professional is. I say, I really don't feel good. I have the symptoms. What should I do? That person right now, as of today, is going to be able to get that test if their doctor or health professional thinks that's appropriate. Is that correct?
It is. I think there is some work to be done to make sure that they can get it as quickly and as easily as it needs to be. So I think that the test is available, but making that patient experience optimal, there's still work to be done so that it gets done same day, gets a result back quickly. There's work to be done there, even though it's available.
Are we getting close to where it would be the same day?
I think we're getting closer, but I wouldn't want to give you a timeline that by X date it's going to be perfect.
Okay. Another question too. We all understand older people are at risk, immunocompromised, they're at risk. A thought that came to me, and I think I know the answer, but pregnant women and their unborn child that hasn't been born yet.
Yeah, I think right now the evidence isn't in. The evidence that there is does not suggest that that is a group that is at particular risk, which is a little bit surprising. But that's the state of science today.
Yep. Israeli researchers have been saying that they're months away from developing a coronavirus vaccine. Any thought on that?
I generally go with Dr. Fauci's talking points on this. There will be a vaccine available pretty soon, but it won't be tested yet, and that's really the time-consuming thing. So I'm actually not sure what the Israelis are promising, but having a vaccine available doesn't mean that it's been shown to be safe and effective, and that is what takes a substantial amount of time. There are 2 cycles of tests that need to be done, so it's going to be a while before we have a vaccine that's approved that we know is safe and effective.
Okay.
The gentleman's time's expired.
Did I go over? Oh, okay, I'm sorry.
Okay, thank you. The chair now recognizes the gentlewoman from Texas, Ms. Jackson Lee.
I thank the chair very much and the chairman and as well the ranking member. Ask unanimous consent to place in the record the American Academy of Family Physicians letter March 11th and a letter from me on February 26th.
Without objection.
Consent. Let me thank both of the witnesses, and very quickly, I have little time, and Dr. Red, let me thank you for your years of service. Can I find out the first moment that this country detected the coronavirus was coming in this direction?
It was in late January, I believe. I can get the date for you, but it was.
But wasn't cases arising in China in 2019?
We believe that there were. The report that they produced was right at the end of December. We think that probably the first cases were sometime in November, detected at some point after that. We think actually
So let me respect what is being done now. Let me publicly say that I believe that this nation was not prepared, equating to its greatness and the responsibility it has not only to 300 million plus, but the world watches us. You are with the CDC. and we needed to be far better prepared. The first thing I want to have is, as members spread out to their districts, we need an 800 number because we cannot use coronavirus.gov and anything else. As members, I've got people calling me and asking, are we closing their schools? So I'm asking both the Deputy Secretary, convey to this task force, set up a number for members of Congress, however you want to have a classified or a code, give us a number to call. Can I have that conveyed and established, please?
I think we can commit to getting you a number that you're going to get an answer to.
I appreciate it. Thank you, Doctor.
I think that the question of whether a particular school is closing or not is not something.
No, I'm just saying these are the kind of calls that are coming in. Let me move on. The level of contagiousness of the coronavirus, would you explain that very briefly, how contagious it is?
Sure. The measure that is used to describe that characteristic of a virus is the number of additional cases that would arise from one case. It's called the R-naught.
And I'm sorry, I'm going to have to ask you to move quickly on that.
Okay.
Yeah.
For influenza, it's 1.5. For this virus, probably somewhere between 2 and 3. So it's more contagious.
It's
than
more
influenza.
contagious. This is the kind of information that really needs to be presented to the public, not out of panic, but in terms of educating them. Let me go to the test kits. You indicated that there was 75,000 to be tested, and is that test kits or test?
Those are tests. And I agree that this nomenclature of kit has been confusing.
Right, so these are individual tests, 75,000.
Correct.
Is the 1 million individual tests as well, or kits?
That's people.
People, so 1 million people possibility, but not yet.
It's been sent out. I think that the availability depends on other factors than the test materials itself, and that's really the logistics of.
But they are going out to labs and local governments, or they're going to physicians and hospitals?
These are the laboratory companies that do these tests.
Right, so you have to access that.
Correct.
And there is a process to be tested. People need to be trained on how you use the test.
So there are people in the laboratory that are trained. It's mainly protecting yourself if you're an individual collecting a specimen.
I've got to go quickly. I thank you. So it's not stand out on the street and get tested or walk into urgent care and possibly get tested?
In the United States, no. In Korea, they have drive-through testing where you get tested in your car.
That's coming to my next point, which is I hope to get in a phone call back if I could. Low-income people, poor people do not have medical providers. They are walking into urgent care, clinics, or hospitals. You have got to be able to respond, and I'm not going to take the answer right now. You've got to be able to respond to that. I do need a one-on-one conversation. Baylor College of Medicine, the infectious disease, has a vaccine with 20,000 vials. They don't have the resources to do the clinical tests. I want them to be connected to the task force to get those clinical tests or to get them connected for resources. They're ready to go right now. They're not Jackleg Joe or somebody down the road in a lab that we can't find. I need that to happen right now. So I don't want, again, can I dialogue to find out how to work that out or who to connect them to?
Yes.
I thank you. Let me ask my good friend here in DHS. We have community spread in Texas, but I take issue with the connecting flights. So our community spread came through a person who came from Italy to Frankfurt to the United States. And CBP is not prepared. You need to implement some form of testing for CBP in terms of asking the question of whether or not the person has come from Italy, period. And the other point is there are 3 TSO officers diagnosed in San Jose. Can you just give me an answer what you're doing to ramp up preparation from those airports? If I can get that answer, I'd appreciate it on the record.
Yep. So
thank you. And Deputy Secretary, thank you.
The 3 TSOs are all at one airport, San Jose International.
Right,
so 46 other employees have been sent home for self-quarantine.
I want to do TSO across the nation. I don't want to. I'm just saying that they are susceptible.
The gentlelady's time has expired, and she posed a number of questions. Perhaps you can submit the answers in writing, sir. The chair now recognizes Mr. Higgins for 5 minutes.
Thank you, Madam Chairwoman. Mr. Cuccinelli, does your job description include advising and reporting the executive and the Department of Homeland Security based upon your mission parameters and your background, your own personal experience and knowledge?
Yes, sir.
And Dr. Redd, does your job description include advising the CDC and HHS regarding your background as a doctor and your specific mission requirements?
It does.
Do you gentlemen know Dr. Anthony Fauci?
Yes.
Would you consider him to be a brilliant scientist with an incredible medical background and an expert on allergy and infectious diseases?
I would.
Would you, Dr. Redd, concur with Dr. Fauci's conclusions that based upon his scientific assessment and his job description as an advisor and a counselor based upon scientific data, would you concur with his conclusion that large gatherings of Americans, it would be best to slow the spread of this virus if there were not large gatherings?
Yes.
Did that concurrence with his opinion, that's based upon science and medicine, is it not?
It is. There are elements to that we could go into, but yes.
So on a clean slate, that's strictly medical and scientific advice, correct? And that's his job, your job, and Mr. Cuccinelli's job is to advise the executive.
Yes, sir.
Did you swore an oath when you took office, did you not, sir?
I did.
Your oath was to the Constitution, was it not?
Yes, sir.
It's been alarming to me to hear suggestions in this committee and others that there seems to be suggestions that there be some federally mandated overriding authority to enforce restrictions of travel of free Americans and to override the authority of sovereign states and the governors thereof to mandate the enforcement of restricted gatherings of free Americans. We are not Italy, we're not South Korea, we're certainly not Beijing, we're not Hong Kong. This is America. I have a great deal of concern that this virus, and let's talk about that for a second. There's been a lot of talk about preparedness in this committee and others. Does the CDC have stockpiles of millions of test kits and vaccines for a virus that may surface next year that we don't know what it is?
No, we do not.
Of course not.
In fact,
when was COVID-19 first discovered within an American certified scientific lab and evaluated, said, yes, this is COVID-19, this is a new virus?
In January 2020.
Thank you very much. Did we have stockpiles of prepared tests? These tests must be virus specific, am I correct?
They are. We started producing them before we had the virus, actually. Once the sequence was produced in early...
But you had the scientific sequence.
We did.
So there's no way for us now to know what that sequence is for a virus that may be discovered next year, is there?
Correct.
So other than having the infrastructure of our massive federal government, working in cooperation with international organizations and our state and local governments, and including private industry, how more prepared could a nation be for an unknown virus than we are right now? Now, surely we'll learn from this. Do you agree?
I do.
We'll be better and stronger as we move forward. Did we learn from SARS?
We did. We've learned quite a bit over the last 20 years in emergency responses. If I could just go back to one of your earlier points, if I may. We work closely with state and local governments. We don't make decisions for what they should do. We're really at their service, providing that kind of technical, scientific guidance that you described. So we don't make those decisions.
I concur, as we should as a federal government and a constitutionalist representative republic of sovereign states.
Yes, sir.
So the governors of our sovereign states have been instructed, advised, and empowered to make decisions within their states. Is that correct?
Absolutely.
Would you see the role of the federal government in any other way?
I wouldn't. I think there are places where things like quarantine authority, there are state authorities, there are federal authorities, and those are things we have to work out. But in general, at CDC, we work in the service of the state governments.
Well, thank you for your service, gentlemen, both of you. Thank you for appearing before this committee today. It's just been fascinating, Madam Chairman. Thank you for holding this hearing.
The chair now recognizes Mr. Thompson.
Let me get something straight, Dr. Red. We just approved $8.3 billion last week to go to state governments because they don't have the capacity to do exactly what we're dealing with. So now, are you agreeing that states ought to do their own thing and the federal government stay out?
We provide advice to states, so we work at their service. We're providing a lot of funding through your appropriation to do the things that we all agree need to be done.
Well, we're giving them a heck of a lot of money. So I don't think you can become a sovereign state and not rely on your federal government to help in times of a pandemic.
Right. Well, I think that we are certainly doing everything we can to support the states, but they will be the ones making these kinds of decisions. I'm not
Dr.
following
Reyes?
you, I think.
I think there's some health decisions CDC makes independent of the states.
We really work, the way that CDC primarily operates is by collecting information, analyzing it, and then translating that into guidance or recommendations. And we work very closely with state health departments and state governments, but at the end of the day, from these kind of things we're talking about, close this event, it's going to be a state decision.
But states rely on CDC.
They do. I
that-
think it's a
that's what I-
partnership, really.
No state on its own can survive a situation that we're dealing with right now without the help of CDC.
Yes. That would be my opinion.
That's what I'm trying to get at. Thank you. I yield back.
Okay, the chair now recognizes Mr. Correa for 5 minutes.
Thank you, Madam Chair, and I want to thank the chairman for holding this most important issue, and I want to welcome both of our witnesses, Dr. Red, Mr. Cuccinelli, for being here today. Just want to say we're all on the same team, so to speak. Mr. Cuccinelli, you said earlier, you don't want to put any words in your mouth, that you didn't want to essentially get in the way of local efforts, didn't want to interfere, didn't want to step in any of those efforts. Is that correct? Something to that effect?
Along the same lines that Dr. Red was just
And the reason I bring that up is I tried to have a town hall last Friday. My town hall in my district was really to get information out. And I encountered very shy county health officials who didn't want to get ahead of this issue. There's a lot of confusion out there right now. And this issue is evolving on a daily basis. World Health Organization just declared a world pandemic. Who's in charge?
the way that the leadership for this
Is
work-
anybody in charge? Is anybody quarterbacking this effort at the federal level? Or is this left to 50 states? And again, just asking because my constituents want to know what's going on. And what really unnerves individuals is you've got information, misinformation coming at you from all sectors. So you got a congressman, not a doctor, holding a town hall trying to explain to people with a couple of other individuals there who are doctors what's going on when my local county health officials don't want to step into this issue. Who's in charge?
So the answer to your question, Congressman, is both, which doesn't help with the confusion side.
Both what?
Our authorities are limited and our capacity.
But you do have a voice
Absolutely.
of authority based on science, we hope,
Yes.
to let people in this country know what the state of this nation is. It's not about states' rights, it's not about federal rights, it's about health issues and science.
So among the things we've been doing, Congressman, I don't even know how many calls I've been on with literally hundreds and thousands of local health officials, legal authorities like
But are we-
county attorneys and so forth.
We need to continue to
talk them
step
through
up
this.
and really make that voice clear and concise to folks as to what we need to do. Very quickly, I'm going to shift over, Dr. Red. Don't want to start any rumors here, but it's my understanding that the World Health Organization created a diagnostic test early on, and offered it to the United States, and that the administration essentially decided to forego using this World Health Organization COVID-19 diagnostic test, and instead to have CDC develop its own. Is that correct?
The tests were being developed at the same time at CDC, and it's actually in Germany where the test was actually being developed. The WHO has kind of a recipe for what the test, kind of the characteristics of the test.
Well, they weren't ahead of us. It was just almost parallel in terms of our efforts?
Correct. It was.
Were those efforts coordinated?
We knew about their test, but in terms of joint development, it was independently developed.
If I would ask, why were we not coordinating? This is a world pandemic. Easy to figure that it's coming our way. China, Italy, Iran. Why would we not coordinate?
At that time, it was just China when we were beginning development of the test. What the issue, maybe gets us a later question that you would have, but when the issues with our test were identified, there was sort of a decision to make about how to proceed in correcting that issue. If we had gone to the other test, we would have kind of gone back to zero with the FDA in terms of the emergency use authorization. So I'm not.
Lessons learned. Can we figure out how to coordinate on a worldwide basis when we're looking at these kinds of world pandemics coming at us? Zika, okay, Ebola, Corona. Something's going to come around the corner, and I think our constituents, our taxpayers, deserve that we learn lessons and react to this stuff on a worldwide basis immediately.
Congressman, can I comment?
Yes, sir.
So on January 6th, CDC reached out to their compatriots, the Chinese CDC, taking its name from ours, and offered to cooperate and to help them. And their scientists, as I understand it, were agreeable to that, were enthusiastic about it, but their political leadership wouldn't act on those communications for weeks and weeks and weeks. And you heard Secretary Azar, I'm sure, publicly complain eventually of that the Chinese were taking so long to let the WHO team into China. That team included American representatives.
Thank you.
Colleagues, members are reminded that votes have now been called. We are going to try to finish up the line of questioning, okay? So we're going to ask members to be thoughtful as they proceed. The chair now recognizes Mr. Richmond for 5 minutes.
Let me just follow up where my colleague left off. And we're talking about lessons learned. And Mr. Cuccinelli, you mentioned that what China wouldn't do. But isn't that what our leadership is supposed to do? I mean, people are not always going to just volunteer and follow, but that's what we have our American leadership for, right?
Well, and our leadership reached out at both the secretary and presidential level. And by secretary, I mean two secretaries, Secretary Azar and Secretary Pompeo, and the president all reached out to their counterparts in China during that time period.
And my suggestion would be sometimes you don't take no for an answer. And that would just, especially when you're playing with something this important. But let me just, I need to just explain to my colleagues, how many tests is South Korea doing a day?
They are doing a very large number of tests each day. They've got 60 sites that are drive-through, many more tests than we're doing.
So people in my district are not going to understand how South Korea are ahead of us because we're the United States of America. And it's not the time to complain about it, but we need to have that figured out. Because let's take a community like New Orleans that is high on tourism. The port is our biggest industry, tourism is our second. When it comes, we're in a world of trouble, especially if we don't have the ability to test like we should. So when do you think we would have that ability in New Orleans to test as we would need?
The ability to test is increasing day by day. We've got two systems to do tests in the United States. We have the public health system. There are 75,000 tests out there in that system now. There are over 1 million tests in the commercial sector, with that number increasing almost daily. The place where we have work to do is making sure that when a doctor decides a patient needs a test, they can get it that day and can get results back quickly. I think from the standpoint of being able to respond effectively and kind of know where we are, a lot of the things that we're doing now are going to clarify actually where we are. For example, community surveillance to make sure if there's a virus, not even having to go and say, I think I have coronavirus, but if you have respiratory symptoms, there are systems around the country that we're standing up to test people, not just for influenza, which is what those systems were designed for, but also for coronavirus. So we'll be able to detect transmission in a way that doesn't require that prompting.
So the technical support that you all are offering to local municipalities, that would include tracing?
It depends on where we are in the epidemic. The contact tracing is a really important measure when you want to extinguish transmission, and that was what we have been doing in the early parts of the epidemic. When you have community transmission, it's just not feasible to do that, and the effort is better directed towards the kind of recommendations that you're seeing in King County, in Santa Clara, in New York, which is protect the elderly and do things at a community level that can prevent transmission.
And that would be my question, because I guess what I'm hearing in New Orleans now, we've put in a request for technical support from the CDC, and it appears that we have a case of an elderly person who lived either in an assisted living or a nursing home. So we're going to need all the help we can get, and we're going to need it real quick. Are you all prepared to assist in an event like that?
So I think that as there are more I think what we need to do is to protect nursing homes. I can't promise you that we're going to send a team to New Orleans, but we are definitely going to help the health department in every way that we can.
Okay, so the answer is you don't know. Let me also ask very quickly, do we think that, and this is about the future, about putting pandemics under the Stafford Act so that when it happens, we can mobilize without having to come to Congress, we can do individual assistance, we can do all the things we need if we put it under Stafford Act included with natural disasters? Is that something we should do?
I think that one of the things that we have learned from previous experiences, very important work that Congress has done, is to create the Infectious Disease Rapid Response Reserve Fund. That allowed us to respond immediately and not be delayed waiting for an appropriation. I think the question of whether the Stafford Act is the right mechanism or not, or there's some other mechanism, is one that I think we need to have a dialogue about. But it's essential that large emergency responses like this not be hindered by the lack of funding.
I yield back.
Thank you. The chair now recognizes Mr. Green from Texas for 5 minutes. Okay. If the gentleman yields to Ms. Titus for 5 minutes.
Well, thank you, Mr. Green. I appreciate that very much. I'll just be brief. Mr. Cuccinelli, I think you said earlier that you rejected the academic models that advised against travel boundaries or travel restrictions and gave the advice to the president to the contrary. What would make you think you could reject an academic model based on scientific study and evidence to advise the president? Was that like bad politics as opposed to good science?
Well, I'm not quite sure how to answer your last question.
Well, I think I know the answer. I think it probably was. I mean, this administration has very little respect for anything intellectual, and this is yet another.
Do you actually want me to answer the question?
Gentleman will suspend.
That's fine.
Gentleman will suspend.
You could answer this question for me, though, Mr. Cuccinelli. As the acting director, you oversaw the rollout of the very cruel public charge rule. Now, we heard yesterday from the director of the CDC that the public charge rule would discourage people from seeking the health care they need amidst this outbreak. Could you comment on this, Dr. Reed? Do you think the fact that people don't have coverage or they're afraid to get Medicaid because they're afraid they'll lose their green card, this could have some impact on the spread of this virus?
I'm not familiar with that rule. I think we should be doing everything we can to make sure that people that need to get tested and need treatment have access to it.
Thank you, Dr. Redd. In light of that, Mr. Cuccinelli, would you recommend that we take away that that public charge rule?
You want me to actually answer?
I would like an answer.
Oh, all right. Well,
It's a yes or no.
no.
Why not?
Oh, I thought it was just yes or no.
That's the second question.
So, because it's completely unrelated. Anyone seeking help or testing or health care related to the coronavirus does not affect a public charge analysis.
I guess the director of the CDC would disagree with you. That's what he testified before House Appropriations yesterday.
If he so testified, he was wrong.
Okay. Thank you. I'll yield back.
The chair now recognizes Mr. Green from Texas for 5 minutes.
Thank you, Madam Chair. Dr. Redd, if I may, and I'll try to move expeditiously because my dear friend Mr. Cleaver is here and I'd like for him to have his turn. You've indicated that in South Korea, they test people in their cars as they drive through. True?
Yes, sir.
And you've indicated that they test some 60,000 people
I didn't give a number, but that sounds right.
per day.
I'm not sure if that, I can't verify that number. We could check. I've got it in here, but I don't recall
How
the
many do
exact
we
number.
test per day in this country?
It's not that high.
Is it 40,000?
So we've, at CDC, we have
Is it
tested
30,000?
1,700 people, 1,784. State health departments
Is
have
it
tested.
20,000?
I'm sorry?
Is it 20,000 per day?
It's not 20,000 a day.
Is it
It's on the
10,000
order
per
of,
day?
I'd really want to get
Is
back
it
to you. with the
5,000 per
numbers.
day?
I'd like to get back to you with the
Is it
numbers.
a number that exceeds 10,000 per day?
It's not a number that exceeds 10,000 a day.
Is it a number that exceeds 5,000 per day?
I'd like to,
Is it a number that exceeds 3,000 per day?
I think it would be better for me to get back
Does
to
it
you with an exact
exceed,
number.
does it exceed 1,000 per day?
As I said before, it'd be better if I got back to you with the correct number.
Is it true that there is a way to test thousands of people per day?
I think that we're going to be seeing that
Is
in
it
the commercial
true that the
sector.
technology exists such that thousands of people per day can be tested?
Yes.
And is it true that if this technology exists, that the United States of America, greatest, richest country in the world, can employ this technology?
I think that we will be doing that in the commercial sector.
Is it true that the United States of America, regardless of setting, can deploy this technology?
It certainly is possible.
And in the United States of America, is it not true that we can put a person on the moon?
We have.
As we have. So is it fair to say that if they're doing it in South Korea, that maybe we could ask them how to do it?
We're in discussions with them about their response. Maybe 2 points to make. I think that at the end of the day,
Is it also true that if we had 1 million people tested, that we would not be able to ascertain the results within any reasonable amount of time because we don't have the methodology, the means by which we can examine the test and do it in an efficacious way such that we can give results with some degree of immediacy? Is this true?
well, it's one of the things that we're working on.
Is it true that
do.
if we had 1 million people tested, we would not be able to get the results back immediately?
I think that the answer to your question.
Is it
depends
true
on the
that it would take
definition of
longer
need.
than a week to do that, to get the results back?
I'm sorry, I'm trying to answer your
I
question.
don't understand it. I'm trying to ask a question. Is it true that it would take longer than 2 weeks to get the results back?
I think that there is a.
It's true that it would take longer than 3 weeks?
I think the systems exist now to get results back to patients more quickly, particularly.
If we had 1 million people tested, we're talking about 1 million. How long?
Well, people get blood tests every day, and there are more than 1 million people, and they get their results back the same
But
day.
I'm asking you about current circumstances. Current circumstances. As we sit here waiting for this answer so that we can vote, how long?
I think what we could get back to you with is for the companies that
The
are able
truth
to do this
is,
on a
there is
routine basis.
there is a way to do this testing. It appears to me that we don't have the will. We don't have the will to move expeditiously, to acquire the technology if we don't have it. We can do this. This country has the ability to get great things done in short order. We, for whatever reason, don't have the will. And the public becomes highly suspect when we don't exercise the will. Where you have few facts, you have much speculation. The speculation is going to run rampant because we don't exhibit the will to do that which can be done.
I respectfully disagree with
I
you.
would expect you to respectfully disagree, but I respectfully disagree with your disagreement, and I yield back the balance of my time.
The chair now recognizes Mr. Cleaver for 5 minutes.
Thank you, Madam Chair. I won't use 5 minutes. Admiral, thank you. This is, I guess, a little personal, but it probably has some applicability to the entire country. My father is 97. He won't take the flu shot because he thinks it'll make him get the flu. And by the way, my grandmother said that messing around with the moon messed up the weather and the flowers. So if we went up there, we made some mistakes while we were on the moon. But let me get back to my dad, because he's healthy as far as we know, 97 years old. But he's already suspicious of things. And then we're told that your shop wanted to advise elderly Americans, not to do certain things because 97 years old or whatever, your immune system is vulnerable, and that it was overruled. I'm concerned about people out here who may be sick, and they're already, older people, already suspicious, and then they can't get accurate information about their immune system and the vulnerability to this galloping virus. We're probably going home tomorrow. We got to deal with, in my real life, I'm a Methodist pastor. I'm going to deal with people this weekend wanting to know what's going on. The White House says, it's okay. You don't need to worry about, the CDC said, if you're an older person, don't get on planes and so forth. Mr. Cuccinelli, would one of you like to come speak to the church? Or call my father.
I think the question of distrust of authorities and, for example, with the influenza vaccination is a really difficult problem. And I think it really gets back to the question of trust that we've talked about to some extent today. And
I'm not blaming you. I just want to know, how did we get into this mess? Because I think it's going to, we could cause some people to.
I think your son is going to believe you more than he's going to believe us. So I would recommend that you give him the advice that's on the CDC website, and do your best to encourage him to stay protected.
But what about flying? What about elderly people flying?
I think that is for a 90-year-old person today. I would not recommend flying.
Well, why would it be overruled? I mean, maybe I'm not articulate enough, but.
Well, actually, in the guidance that we have, we do recommend that for.
I hate to cut you off, but earlier we would, the White House said don't make that information available. And that's all I want to know is why.
No, sir. There has not been a point where we've said, or anyone at the White House has said, don't make X information available.
Okay. Well, these news reports are, I guess.
I think maybe there's an interpretation of closed space with limited air circulation, and that, there are ways to interpret that.
Okay. I don't have time. There are news reports I don't have time to do this in here right now, but I have news reports. I can get it to you which said that CDC said they wanted to issue this warning to the elderly, and they were told not to do it by the White House.
I think you asked me for an interpretation of our guidance, and that was the
And I
interpretation
appreciate
gave.
that. I appreciate that.
Yeah, and Congressman, I've participated in the task force, and CDC has been a critical central member of it from the beginning, of course. And as Dr. Fauci testified in he didn't testify, it was a press conference. As he said, when he was directly asked, have you been muzzled? He said, I've been doing this for 30 plus years. I don't remember his whole exact answer. He said, nobody has told me to not say anything.
I heard
and that's been the case with the CDC as well.
Thank you.
Okay, the gentleman's time has expired. I ask unanimous consent to enter into the record a statement from the American Federation of Government Employees without objection. I thank the witnesses for their valuable testimony and the members for their questions. The members of this committee may have additional questions for the witnesses, and we ask that you respond expeditiously in writing to those questions. Without objection, the committee record shall be kept open for 10 days. Hearing no further business, the committee stands adjourned.